Good morning. I'm Deanna Ziemba, Vice President of Business Development and Marketing at Charles E. Smith Life Communities. It is my honor and privilege to be your MC of the 11th Annual Sara and Samuel J. Lessans Healthcare Symposium. We are thrilled you could join us for the second session of our COVID-19 pandemic mental health effects on older adults and their healthcare provider series. Today's session will be mental health support for healthcare professionals. Before we continue, I'd like to take a moment to thank all of the amazing heroes attending today. It has been a long and challenging year and a half. We appreciate you, everything you do for our residents, our patients, and the community. Thank you for what you do each and every day. We are fortunate to have support and dedication of partners, sponsors, and committee members to host this amazing symposium. I'd like to take a moment to thank and recognize them. Our partner, Suburban Hospital, a member of Johns Hopkins Medicine, we are glad to have them as a partner in the extensive planning of this important event. As a special recognition and thank you to Doctors Stuart and Ellen Lessans for their continued support of this program, which, as I bet you can imagine, is named for Dr. Stewart's parents, Sara and Samuel Lessans. Thank you so much. I would also like to thank our sponsors, Optum and Minkoff Company, for their support and dedication. We'd like to take a moment to recognize HFAM, the Healthcare Facilities Association of Maryland, for making it possible for us to offer continuing educations for Maryland social workers and nursing home administrators. Those of you attending today will receive 1.5 hours of continuing education credits. We are very excited to also share that we've received approval from Maryland's Nursing Association to offer 1.5 continuing education credits for nursing. For those requiring social worker, nursing home administrator continuing education credits, please know that we will provide an attendee list to HFAM to confirm your participation. We will also provide an attendee list to the Maryland Nursing Association for those nurses requiring continuing education credits. Following this program, you'll receive an evaluation. Please include your name and email address on that form when you return it. It will come in the form of a survey monkey. Once we receive the completed survey, you will receive your certificate. Finally, I would like to take a moment and have a special acknowledgement and thank you to our Symposium Planning Committee. Their dedication, support, and expertise are what make this event such a success. They plan for over a year. Thank you so much. Thank you to all of our partners, sponsors, and committee members. Now I'd like to welcome our President and CEO, Bruce Lederman.
Hello, I am Bruce Lederman, and as President and CEO of Charles E. Smith Life Communities, it is my pleasure to welcome you to the 11th Annual Sara and Samuel J. Lessans Healthcare Symposium. We are honored to present this event every year to provide education on relevant topics impacting the lives of older adults, and we are very glad you are able to join us virtually. I would like to recognize and thank Doctors Ellen and Stuart Lessans, who make this symposium possible, in loving memory of Stuart's parents, Sara and Samuel J. Lessans. For over 100 years at Charles E. Smith Life Communities, we have remained committed to providing quality care and meaningful life experiences for older adults. On any given day, those we serve are living their best lives on our campus in Rockville, Maryland, just outside Washington, D.C. Among the lifestyle options we offer for 1,100 older adults are at Revitz House and Ring House residences, where we provide vibrant and healthy aging in apartment-style living. At Landau House and Cohn Rosen House, where assisted living is available, and additional memory care support for those who are living with cognitive decline. And for those who require a short stay, our therapy and medical teams are available at the Warren Slavin Post-Acute Care Center, located in the Hebrew Home of Greater Washington, and where we also provide long-term nursing care. Thank you again for attending the symposium, and to learn more about CESLC, please visit our website at smithlifecommunities.org. Thank you.
Good morning, everyone. My name is Kathleen McGinnis, and I'm Director of Community Relations and a certified dementia practitioner for Smith Life Home Care. Smith Life Home Care is a partner company affiliated with Charles E. Smith Life Communities. We are honored to be a part of their community for more than 20 years. We have provided safe, kind, and vaccinated certified nursing assistants to hundreds of families on the Charles E. Smith Life Communities campus and provided support for thousands of families for safe hospital discharges in Montgomery County and recently Washington, D.C. We want to thank all of our community partners and mental health professionals for their partnership in care and their amazing pandemic support this past year. Now, 2 quick slides from Smith Life Home Care. So, as I mentioned, for over 20 years, Smith Life Home Care has been providing as much or as little care to support families on the Charles E. Smith Life Communities campus, Montgomery County, and Washington, D.C. We feature personal care and health support, lifestyle services, short-term care, long-term care, 24/7 care, and special discharge services. For an added value, we offer an electronic family room online care portal to help you better communicate with your caregivers, a free home safety inspection, 24/7 phone line, and confidence knowing that you're choosing an award-winning company in Smith Life Home Care. Call 301-816-5020 or visit www.smithlifehomecare.com for more information. One final slide on how we can help you in a short-term way. As I said, we've been passionate about providing our clients with the best care your loved one can receive for the best possible outcome. Something that's of interest to many families in the community has been our short-term discharge packages. Home and Settled is $135. This has high value for people that don't have families living nearby. 5 hours of home care service with a certified nursing assistant who can pick you up at your home in Montgomery County or Washington, D.C., take you to a medical appointment, or take you home from the hospital, stop at the pharmacy in Montgomery County or Northwest Washington, D.C. And last but not least, we have another short-term package, Transition to Home, which is greatly utilized by knee and hip replacement folks who just need maybe 18 hours of care or 3 to help them settle into their rehab at home in Montgomery County or Washington, D.C. Of course, we'd like to lend our thanks to the Symposium Planning Committee for all of their hard work and community education over the past year and ongoing. Thank you again for allowing us to be part of this special program. And now back to Deanna.
Thank you, Kathleen. And thank you, Kathleen and Smith Life, for your amazing partnership. Our second session, Mental Health Support for Healthcare Professionals, will be led by Dr. Matthew Rutherford and Dr. Mullen Lesh. Dr. Matthew Rutherford is Program Chief and Adult Interventionist interventions in the Division of Services and Intervention Research at the National Institute of Mental Health. In this position, Dr. Rutherford helps oversee and provide scientific liaison to NIMH-supported clinical trials at universities across the country, aimed at studying personalized treatment of mental health disorders across the lifespan. During his career at NIMH, he has led an annual national treatment research meeting, has worked as editor-in-chief of peer-reviewed journal, psychopharmacological, excuse me today, my tongue is getting a little tied there, I apologize, psychopharmacological bulletin, and has served as a member and chair of the FDA Psychopharmacological Drugs Advisory Committee. He is a distinguished life fellow of the American Psychiatric Association, and he received a Meritorious Service Award for the Washington Psychiatric Society for his ongoing leadership of the Continuing Medical Education Committee. Dr. Rutherford is a board certified in psychiatric and clinical pharmacology. He received his medical degree from the State University of New York, Downstate Medical Center, and trained in psychiatry at Washington University in St. Louis. Presently, he maintains a private practice in psychiatry and psychopharmacology. I apologize. I am really struggling with my words this morning. Dr. Mullen Lesh is a professor in the Department of Psychiatry at Mount Sinai Hospital, Joseph and Wolf Health Complex. And interesting facts I learned about that is Dr. Joseph and his brother, Wolf, donated the largest hospital donation in Canada of $50 million. And that is where that name came from. Sinai Health System at the University of Toronto. Dr. Lesh academic and clinical work has focused on broadening the application of psychotherapy within psychiatry. Dr. Lesh lectures broadly and has published in group therapy literature regarding interactive and interpersonal approaches in psychotherapy, group psychotherapy for patients with schizophrenic, evidence-based approaches to group therapy, and modified interpersonal group psychotherapy for patients with substance abuse. Group psychotherapy applications for geriatric depression and for medically ill. He has co-authored a book with the 5th edition of the Theory and Practice of Group Psychotherapy, also translated into German, Hebrew, Greek, Polish, Czech, Spanish, Russian, Portuguese editions. Whew. Dr. Lesh has been awarded fellowship in Canadian Group Psychotherapy Association and was recognized as the Distinguished Fellow of the American Group Psychotherapy Association. Dr. Lesh is on the board of directors of the National Registry of Certified Group Therapists, and he is a co-chair of the AGPA Science to Services Task Force, leading to the 2008 publication of Clinical Practice Guidelines for Group Psychotherapy, for which he was awarded the 2009 Anne Onslow Award for Outstanding Contributions for Psychodynamic Group Therapy. Dr. Lesh has been the recipient of a number of teaching awards at the University of Toronto. We are thrilled and honored to have both of these amazing doctors here today to lead us in our presentation. I'd like to start this presentation with Dr. Lesh, and then it will be followed by Dr. Rutherford.
Thank you so much, Deanna, for those introductions. I'm delighted to be with you today and to co-present with Matt. The focus of the morning on mental health effects on healthcare providers and ways in which we can help support our colleagues, I see as a reflection of this organization's attention to the needs of the people who work within the organization. So I'm very, very pleased to be here. I'm going to talk about the literature about healthcare providers in the face of the stresses of COVID. And I'm going to talk about leadership. I'm going to talk about wellness. Let me begin with a quote from a member of a group that I facilitate at the Faculty of Medicine in the University of Toronto. And the focus of this group is leading for wellness, to support leaders so that they can provide support for healthcare workers, trainees, students, and colleagues within their own departments and hospitals. This woman wrote to me after a meeting saying, this group has been incredibly helpful. As with so many things that we cannot change and must learn to accept, having someone validate and bear witness to our distress or suffering is a powerful solve for the grief, anxiety, and upset that is an inherent part of the human condition and has been so amplified and accentuated during COVID. Can I have a next slide, please? So I'm hoping in the half hour or so that I have with you to address these learning objectives, to talk about how pandemics are traumatic stressors on physicians and healthcare workers, to describe principles of support and implementation for our colleagues and trainees, to share with you some of the things that have emerged from group support sessions and leading for wellness groups that I have been facilitating, to talk about organizational culture and psychological safety in the workplace, and to broaden our idea of PPE beyond personal protective equipment to personal and psychological protective equipment. I receive royalties from a couple of publishing houses for books that I've published. Otherwise, I have no conflicts to declare. Next, please. So we are embedded in this COVID crisis, and I think it is worthwhile always to consider the idea of crisis has a blend of danger, which we are acutely aware of, and opportunity. I'm going to talk first about the danger, and then I'll talk about the opportunity. What is clear is that healthcare providers are experiencing unprecedented, significant, and possibly enduring psychological distress. Concerns relate to personal safety and risk, spread of virus to family, access to personal protective equipment, ethical dilemmas, moral distress, the kind of situation where you are not able to practice care according to the values and training that you have. In hospital environments, in the depth of a COVID environment, people were redeployed out of their areas of normal expertise, which generated enormous anxiety. The work was unrelenting. Healthcare workers were stigmatized. There were feelings of guilt, economic worry, and what we have seen is accelerated professional career departures. People leaving the field because they feel overwhelmed. Thankfully, I think we have turned the corner on the deepest threats of COVID, but in Ontario, where I reside, we were preparing for unprecedented critical care triage protocols to help make decisions about what do you do when you have 10 people who need intensive care and you only have 5 beds. How do you prioritize? Awful dilemmas. The opportunity that's emerged from this is that mental health awareness has never been more prominent across all American and Canadian organizations for physicians and nurses, motivated in part by the tragedy of suicides from physicians and healthcare workers who've been overwhelmed by the challenges of COVID. And what I'm going to spend the rest of my time talking about are principles that I hope transduce into implementation to contribute to a healthier work environment. Next, please. Most important consideration is human capital. Hospitals, healthcare facilities always think about resources, But the most important resource is human capital. And what we have learned is that having an embedded mental health presence in your general hospital, general care setting helps frontline workers plan, train, and prepare around managing stress and demands of pandemic care. Do not assume people will do this without particular training. And there's very good evidence that people who are well trained, well prepared, and have supports manage this stress much more effectively. And people may be familiar with the concept of a triple aim, which has now been expanded to the quadruple aim in healthcare, which is we want healthcare that manages costs, produces better outcomes, produces better patient experience, and produces a better healthcare provider experience. And sometimes this requires a bit of work and persuasion on our part because most healthcare providers fear the stigma around mental health and resist care. But there's research engagements. Next, please. At the organizational level, we must work to create organizational trust, which is a reflection of the people who work in that organization seeing their leadership demonstrate three dimensions. Leadership must be competent, leadership must operate with integrity, and leadership must operate with benevolence. It's particularly important around ethics of care, access to resources, and operating with a commitment to organizational justice so that people know people are being treated fairly within the organization in terms of relational issues, and decisions are made with clarity that reflects justice and principles. Particularly important in this current era with regard to gender and diversity and issues around racism and privilege. We have to be mindful about who gets advantaged and who gets disadvantaged with every decision that we make, from deployment, redeployment, to vaccine equity and distribution. Next, please. Communication in our organizations must be clear, consistent, transparent, timely, and recognize that you are communicating not only to the frontline workers, but to their families, the people they go home to, and have to explain to them what they are doing during the day. We have to recognize the cultural diversity of staff and issues around power, equity, authority, are all influenced by people's cultural background and diversity. We have certainly found education about trauma and stress symptoms is helpful. It protects people from thinking that there's something wrong with them when they realize what they are experiencing with nightmares, with hypervigilance, with anxiety, with avoidance, are normative responses to this incredibly stressful situation. As Daniel Siegel has noted, if you can name it, you can tame it. And we have an obligation to help our people name what they're dealing with. Next, please. We want to create a caring and creative, responsive environment. It's a measure of how we value our colleagues. There's a lovely paper written last year that says healthcare workers have 5 needs: hear me, protect me, prepare me, support me, care for me. And we have to operationalize in each of those domains with a shift to wellness-centered leadership. We destigmatize vulnerability and provide access to support, recognizing that if we're unprepared, people suffer. And if our healthcare providers suffer, the quality of care will inevitably suffer. And we recognize the particular strains that nurses are under. They make up the largest share of healthcare providers in hospital settings and in home care settings, and are particularly at risk, especially with the dual demands of family responsibilities at the end of the day. Next, please. We can anticipate that there will be more conflict as the system comes under pressure. Interpersonal stresses will become more prominent, and people lose the capacity when they're under stress to reflect, and we move into a kind of highly reactive mode. Prior fault lines will become illuminated, and we need to help train people how to deal with interpersonal conflict, how to communicate effectively so that people can engage assertively, but with a seeking of connection rather than with blame and attack. The old adage here is fight fire with water, not fight fire with fire. Next, please. At the heart of everything we do, we need to ensure social connection for our healthcare colleagues. Social isolation and stigma can be offset by social integration in whatever form it takes. Check-ins, formal peer support, informal peer support, buddying up people. In some hospitals in Toronto, every frontline worker has a buddy. Every team has a huddle at the beginning and end of the day. At my hospital, those huddles include a mental health professional who comes and spends 5 minutes at the beginning of a shift, 5 minutes at the end of a shift, talking about support, coping mechanisms, and helping maintain that reflective space. Next, please. If you are running groups in an active fashion, cohesion is critically important. These groups have to be safe places that depathologize anxiety and psychological distress and help people cope with injuries to their sense of self and to their sense of professionalism. I quote Judith Herman, the solidarity of a group provides the strongest protection against terror and despair and the strongest antidote to traumatic experience. Next, please. Group interventions, if you're running such groups, should carry these 5 hallmark features. This is not about critical incident debriefing, which it can raise emotions. This is about creating safety, creating calming, restoring a sense of team and self-efficacy, promoting connectedness, and promoting hope. So those principles have to be guiding you in leading such groups. Normalize, address the reality, do not amplify it, do not diminish it, but help people to cope with it and restore a sense of connection and safety. Next, please. Working within a complex system, I have found this principle to be very helpful, which is that I always promise people confidentiality at the individual level, but I always secure consent to utilize the themes that emerge from any huddles, groups, to bring forward to senior leadership to maximize the organization and leaders' responsiveness. Next, please. Part of what we also teach and communicate are coping strategies. And here we borrow from the coping literature for individuals facing medical illness and make use of a tripartite model of emotion, problem, and meaning-focused coping. A lot of what you're going to hear in the next couple of minutes from me about coping all makes sense. But the issue is we need access to this explicitly rather than to rely on it implicitly. Because when the rubber hits the road, we can forget that kind of internal understanding. And we need to have a kind of clear, explicit pathway forward. Next, please. So the first part of the tripartite coping is emotion-focused coping. To reiterate, social support, the power of social integration, reducing isolation, ventilation, talking, grieving. The grief load that many frontline providers have carried this past year with COVID is enormous. I've heard many providers say they have encountered more death in the last year than they have in 20 years of healthcare. We want to facilitate communication, give people an emotional language and literacy, accept and normalize vulnerability rather than deny emotions, and protect people from tentativeness that leads to further isolation. Next, please. Problem-focused coping tackles particular issues at a behavioral and practical level. You'll see I've highlighted the word sleep because evidence supports the fact that if you want people to function, you have to make sure they get reasonable sleep, along with exercise, diet, avoiding substance use, making use of other self-care techniques, shift work, managing shift work properly, trying to help people get onto a regular schedule as much as possible is critically important. Simplify tasks, shorten shifts if you can, redefine professionalism so it makes space for recognition of personal limits. Advocate, sometimes even with the media. If when with SARS, we saw, which was the first big epidemic we faced in Toronto, we found the media was very critical of healthcare providers as being sources of vectors for the spread of infection, which was very damaging to morale. And we mounted a campaign to help educate the media about how destructive and inaccurate that was. And now, of course, healthcare workers are seen as heroes, which I think helps maintain morale much more effectively. Next, please. If you can't fix a problem through emotion coping, and you can't improve it by problem-based coping, you sometimes have to rely on meaning-focused coping. Extracting meaning, the spiritual dimensions of the work that we do, and connecting to the moral purpose of the work that we do. Philosophers have long stated, if you know why you're doing something, you will find the how. Important here to honor the dignity of the work that we do, and to look for opportunities for post-traumatic growth, being better after. And I'm going to say more about that before I conclude. Part of the meaning-focused coping involves being mindfully engaged with life in a moment-to-moment fashion. That is part of what I was referring to earlier on the earlier slide about the value of mindfulness, meditation. These things, there's good evidence to support their value in helping calm emotional distress and creating more space for thinking and planning. Next, please. Culture is critically important. The best organizations are ones that aim for congruence, that you can see the value principles of care running through from the top of the organization all the way through to every person who works in an organization. It comes from the top. You can't have a high value culture in a situation without leadership from the top. Organizational psychologists will tell you every day, culture eats strategy for breakfast. So you gotta really be clear about how you want to operationalize the culture that you want for your organization. Some of the things that are of value is for leaders to model transparency. It reduces people's assumptions and projections, and it increases acceptance of normative vulnerability. And it signals we are a learning organization. You have things of great value to offer to us, and as healthcare providers in our setting, and we want to learn from you. We want a leadership that promotes a sense of attachment security, that it is safe for me here. I can belong here. People care about me. They recognize, they validate. Our interpersonal relationships are important neurobiological regulators. They help us to manage stress. And I have heard countless stories from healthcare providers, ranging from young nurses to mature physicians, who describe the pain of not being seen, not being recognized within their environments. We have to create psychologically safe workplaces, which in essence means we do everything reasonably possible to avoid what we can foresee as damaging to the mental health of our colleagues and employees. Next, please. Psychological safety, we can think of as a kind of amalgam of how much control does an individual have and how is that person being rewarded and recognized, has an offset against the demands and efforts that the organization or that individual makes on him or herself. A psychologically safer environment is one where people feel rewarded, recognized, and have a degree of autonomy and control, and the demands and efforts are manageable. An unsafe environment is one where people do not have autonomy, feel unrecognized, and the demands and efforts are unrelenting. Not only is this good for the welfare of the people who work in our hospitals and home settings, home care settings, institutional settings, in many jurisdictions, there's an ethical, legislative, clinical, and economic imperative, as I'll show you in just a moment. We want our workplaces to be environments where it's safe to voice your opinion, where leadership invites constructive conflict without shaming or attack, and leaders do the following. They set the stage by being clear about shared expectations of safety, justice, and purpose of our work. They invite participation by acknowledging gaps. They manifest humility about the things that they don't know or need to learn more about. And they operate with genuine inquiry. And when people come forward, they respond productively without shaming and value the input. Next, please. There is mounting evidence that the culture of organization has significant clinical outcome on impact of care. This is particularly so where psychosocial care is at the heart of the work. So having the right culture is going to increase your effectiveness. That's not just a motherhood and apple pie statement. It is evidence-based. Recognize the value of organizational culture, climate, and that what happens at one level of the system through a process of isomorphy runs through every level of the system. The best clinical care is delivered when providers are cared for well. Next, please. This is a slide that looks at the degree to which patient care is influenced by the degree of healthcare provider engagement. And you can see in the top row where there is high levels of engagement, staff feel valued, respected, seen, that the vast majority of time they are providing high levels of patient care. Compare that to the bottom. We have low engagement. You're less likely, significantly, to provide high quality care, which then becomes a kind of a maladaptive loop in and of itself. It becomes demoralizing and disheartening. We want to be in high engagement settings that provide high levels of care. Next, please. In environments that aren't able to meet these challenges, we encounter high levels of burnout. Burnout can be defined by three dimensions: a sense of emotional exhaustion, a sense of feeling futile and ineffective in the work that I do, and a sense of depersonalization, and that I care less about people. It feels less of a human endeavor, more mechanistic. Although we focus on burnout as reflected in the individual who suffers burnout, it is by and large an organizational issue. And it builds atop providers' perfectionism, feelings of doubt and sense of responsibility. And scarily enough, before COVID, half of physicians and postgraduate trainees reported high levels of burnout. You can imagine what those levels look like now. And those of us who work in psychiatry or mental health providers, we've always been particularly vulnerable to burnout because of the high emotional intensity of the work that we do, exposure to trauma, confrontation with the limits of our skills and efficacy, and the horror of patient suicide. These phenomena, set aside patient suicide, are now being felt by ICU nurses, frontline doctors, because of the affective intensity and exposure to the traumatic nature of the work that we're doing. There are three drivers that make burnout worse or can make burnout better and less prominent. Connection, a feeling of competence, and a feeling of personal control. Everything that we do that enhances connection, that enhances a sense of competence, and enhances a sense of personal control reduces burnout. And it is far better to reduce, to avoid burnout rather than to try to treat it. Next, please. Burnout impacts us at least three levels. At the personal level, our relationships suffer, and we suffer psychologically. At the patient care level, we operate with less empathy, which drives down patient satisfaction and marked by poor communication and disengagement. And at the systems level, it means healthcare providers leave the workforce prematurely. And some who continue to work without their heart in it. As I said, it's better to prevent than to treat. It's important to focus on this as an organizational level issue. Our aim should be to enhance self-efficacy, connection, competence, and control. And there's good research that shows, again, it comes from the top. And then the more aligned the values are from the top to the bottom in the hierarchy of a hospital, the less vulnerable people in that organization will be to burnout. Next, please. These are some of the programs that have been tried and look promising with regard to integrating the delivery of interventions in the spirit that I've been talking about. Psychological first aid. We should all be trained in psychological first aid. That's much more important than the hazmat training that I've taken every year at my hospital. And I've never come close to any hazardous material. But I know that everyone who works in the hospital comes close to the need every day for helping someone else with psychological first aid, contact, engagement, an opportunity to talk without judgment and shame, reducing isolation, offering practical assistance, coping, and linking to resources. These are some of the different programs that have been described in the literature in this last while. I'm not going to spend time talking about them now because I suspect Matt is going to be talking about programs like this. But all of these involve the principles of integration, training, social support, enhancing competence. Next, please. My last slide I want to leave you with. I want to close with a focus on opportunity. Many of us have heard the adage of don't waste a crisis. I am hoping that we can aim to be better after COVID, beyond resilience, which gets us back to where we were, to an anti-fragility perspective where we are better than we were before, and that we engage the existential confrontations we have faced to promote post-traumatic growth. So what does being better after for doctors and healthcare providers look like? It means greater mental health awareness. It means destigmatizing mental illness and personal vulnerability. It means enhancing work-life balance. It means enhancing interprofessionalism and respect across specialties and disciplines. It means greater attention to diversity, equity, and inclusion. Racial injustice, which has been the second pandemic that has gripped us alongside COVID. Social justice has never been more prominent and must be addressed and requires a system evolution rather than accepting defeat. We also have now a unique opportunity to train the next generation of professionals in what it really means to be a professional in the current era. We are reminded finally that we are all interconnected in every way, not only through the spread of a virus, but through the spread of support, care, and the deepening of social capital. We and our leaders need to engage in communities of practice to support these imperatives. Thank you for your attention. I'm going to stop there. And now it's my great pleasure to shift things over to Matt Rodorfer.
Thank you, Mullen, and good morning. I'm delighted to continue the important and timely discussion of mental health support for healthcare professionals in the context of the COVID pandemic, with some elaboration of themes so eloquently presented by my distinguished colleague, Dr. Lesh. I'll also be discussing some new research while looking ahead to the implications of our presentations for dealing with these mental health services and intervention challenges as the pandemic subsides in the months and years ahead. I have no conflicts of interest to disclose, and my opinions are my own. I do have one family tie to the Charles E. Smith Life communities. Many of you know my wife, Lori, who's social worker at the Revitz House. While Revitz is one of the independent living facilities on campus and not an actual healthcare facility, it has not been immune from the many COVID-related stresses that Dr. Eichberg articulated so clearly last week. For much of the past year, Lori and her colleagues donned some personal protective equipment and, as needed, staffed the guardian table at the entrance, screening the few permissible visitors for telltale signs of infection. While they did an excellent job of protecting the residents from the virus, neither staff nor the mostly older folks living at Revitz could escape from the stress and disappointment resulting from the necessary social isolation, with the loosening of family connections and the suspension of group activities and meals, and even sitting and schmoozing in the lobby. As we heard in session one, from its earliest months, the COVID pandemic took a toll on the mental health of the US population at large. By mid-2020, the CDC was reporting dramatic increases in symptoms of mental distress, with over 40% of US adults acknowledging problems ranging from anxiety and depression to initiation or expansion of substance use to an endorsement of serious suicidal ideation by 11% of the adult population. Given the relentless nature of the deadly pandemic and the ineffectual response to it for many months, it's not surprising that the toll on overworked and overwhelmed healthcare workers was especially severe. By the summer of last year, signs proclaiming heroes work here, shown here in front of Suburban Hospital in Bethesda, were common and sincere, consistent with the evening ritual in New York City and elsewhere of stepping outside and banging pots and pans as a sign of appreciation to healthcare workers at the time of shift change. While the salute to staff was well-deserved, behind the scenes, adaptations to COVID reality were required and ever evolving. Out of the photo's frame, another sign outside Suburban reminded would-be patients of the challenges ahead. Oh, we can go back one slide. Appended to the arrow directing arriving traffic to the emergency room was the notice, quote, drop-offs only, unquote. Similar efforts at limiting the capacity in the ER while whisking COVID-positive patients to isolation wards without even setting foot in the emergency department were undertaken by many hospitals, such as MedStar Georgetown, seen here on the left, which erected tents outside the actual ER for screening and triage. Next slide, please. Inside busy healthcare facilities, staff and administrators struggled to keep up with a seemingly endless stream of desperately ill COVID victims, with at first only the flimsiest tools available to help them. Personal protective equipment, PPE, was in short supply, and recycling disposable face masks meant for one-time use was common. When the stock of protective gowns was exhausted, resourceful nurses in the intensive care unit pictured here resorted to covering their scrubs with repurposed trash bags. According to a firsthand account shared with me, at one large healthcare facility, administrators were so fearful of virus exposure and spread during patient care that resuscitation efforts were temporarily banned and staff prohibited from even bringing the crash cart into the room. Sure enough, it did not take long before a COVID-positive patient's heart went into potentially fatal ventricular fibrillation. The staff froze while they considered the ban on resuscitation for about a millisecond until a nurse in makeshift PPE rushed into the hall and returned bearing a defibrillator. It took one jolt to save the man's life. Did I mention that heroes were involved? Next slide, please. While all healthcare workers tend to be lumped together, in some ways the distinctions among them have gone beyond their job descriptions during the pandemic. Paramedics, often charged with the sometimes impossible task of keeping desperately ill patients alive during harrowing ambulance rides to precariously welcoming emergency rooms, experience as high a stress level as any first responder. The story from last winter shown here quoted one ambulance company executive as acknowledging a boost in pandemic year early retirements among his emergency medical technicians, who often cited fear of catching the virus themselves. In speaking with pre-hospital workers, I've learned of a less visible financial stress on many paramedics. While few envy the doctors and nurses working double shifts and more, most EMTs are employed within local fire departments, whose tight budgets rarely allow for overtime pay. What is worse, many local jurisdictions, fearful of infection of their frontline employees, abruptly withdrew permission for moonlighting at a second job, which was often necessary to make ends meet. An all too common scenario, I was told, was the EMT prevented from working overtime or a side hustle whose spouse was caught up in a COVID-related layoff, abruptly transforming the family from one with 2.5 incomes to one with a single job holder. Next slide, please. Among the myriad surveys conducted to assess and quantify the mental health impact of the pandemic on healthcare workers, the one commissioned by Mental Health America in May through September of last year, which included over 1,100 individuals, is among the most comprehensive. Next slide, please. Turning to the results, the pie chart at the top depicts a typical question, asking nurses if they felt that they had adequate emotional support. 1.5 times as many replied in the negative than the positive, with 1/4 of the sample unsure, which of course sounds less than optimal. Other findings in the survey confirmed the emotional toll of the pandemic on healthcare workers, 3/4 of whom acknowledged feelings of being overwhelmed, emotionally and physically exhausted, and or burned out. At the height of the pandemic, about half of healthcare workers were worried about inadvertently exposing family members to COVID. Increased challenges with parenting were common, aggravated in many families by the loss of childcare and the struggles of school-aged children at home dealing with remote classes. Next slide, please. These disturbing survey results are consistent with other findings of job dissatisfaction among pandemic-weary healthcare workers. With this startling headline that having been burned out by the pandemic, 3 in 10 healthcare workers were considering leaving the field. Earlier this year, the Washington Post noted that, quote, after a year of trauma, doctors, nurses, and other health workers are struggling to cope, unquote. Next slide, please. Lest we forget, COVID remains a global pandemic. With the Delta variant of the virus surging, these physicians in India, working 48-hour shifts amidst an overwhelmed healthcare system, returned to full PPE to make rounds only a month ago. A colleague described to me his family in Delhi being forced to buy oxygen on the black market for ill relatives. Next slide, please. Meanwhile, here in the US, the politicalization of the Chinese origin of the coronavirus is thought to have contributed to a rise of anti-Asian feelings and even verbal and physical attacks on Asian Americans, including healthcare workers. Next slide, please. Perhaps the saddest story of the mental health toll of the COVID public health crisis on healthcare workers is illustrated in the case of esteemed emergency physician Dr. Lorna Breen, whose death by suicide in the early weeks of the pandemic as New York City hospitals were inundated and overwhelmed by virus infections and fatalities, shocked and horrified the field and the public. In April 2020, the month she died, the New York Times concisely reported, quote, for many New Yorkers, the time of coronavirus will be defined by 2 sounds. One is the ambulance siren, shrieking at all hours through deserted streets. The other is the opposite, the nightly 7 o'clock cheer for frontline workers. Next slide, please. While research efforts aimed at combating the pandemic naturally focused primarily on understanding the virus and developing effective treatments and ultimately vaccines, parallel efforts at confronting the mental health impact were launched from the earliest days of the pandemic. The National Institutes of Health, with a main campus in Bethesda and pre-pandemic office space down the road from Charles E. Smith Life Communities, is the nation's largest supporter of biomedical research. While the 27 institutes and centers that constitute the NIH invest tens of billions of dollars annually in basic and clinical research at universities across the country, which make up the extramural research community, about 10% of the NIH budget is devoted to hands-on research in the intramural laboratories and clinics on the NIH campus, much of it in the clinical center, pictured here, the largest research hospital in the world. This distinction is especially noteworthy in crisis situations because while extramural research at universities must undergo many months of protocol writing and approvals, followed by multiple levels of peer and institute review prior to funding, intramural investigators on the NIH campus, essentially pre-funded to conduct research with limited review for safety, are able to launch research projects quickly, so are able to take advantage of unexpected time-sensitive opportunities. Next slide, please. The NIMH Intramural Research Program response to COVID-19 was built around the theme of, quote, act early in response to public health emergency, unquote. Beyond the goal of targeting specific populations, including, of course, healthcare workers, the aim of the intramural research effort, and the one that is bearing the greatest fruit, has been methods development. In particular, initiatives utilizing online platforms for data collection and tracking changes over time using repeated measures are proving invaluable in developing a full picture of the mental health complications of COVID and the development of personalized approaches to deal with them. Next slide, please. Dr. Joyce Chung, Deputy Clinical Director of the NIMH Intramural Program, has won praise from the field for establishing a template for systematically tracking mental health effects of COVID over time. While this initial effort was not directed specifically at healthcare workers, it's now been adapted to target various specific subgroups of the population. It serves as a model of longitudinal study in the community by establishing a few basic principles in a simple, straightforward design. These are being widely applied in studies of healthcare workers and other specific participant populations. First, the subject should be easily accessible and motivated to participate. In this case, she's focused on individuals who had previously participated in NIMH studies, easily meeting that criterion. Second, keep the research burden on subjects reasonable. While it's important to get necessary information from participants, the cost of participation in terms of time and effort cannot be so great as to encourage dropout from the study along the way. In this case, a limited, no-frills questionnaire asking about exposure to COVID and testing, along with adapted checklists for symptoms of stress, anxiety, and depression were constructed, and by presenting it to participants to complete on the web only every other week, enhanced the likelihood of continued participation over a 6-month period, providing information necessary to flesh out the picture of the mental health toll of COVID, complementing the existing single time point surveys that have been standard. In that spirit, next slide, please, Drs. Carlos Zarate and Larry Park launched a similar pilot project aimed specifically at healthcare workers, an initial effort by this premier intramural research group at the pivoting from in-person to remote interaction that defined the field as the pandemic took hold in 2020. Just as many clinicians have shifted to treating patients remotely, so too the research world has had to make the same adaptation. The feasibility of the new methodology for obtaining informed consent and gathering data using an online tool was demonstrated here with over 900 healthcare workers providing data using online questionnaires and rating forms. Importantly, as with the Chung study, the short latency of response between the onset of the mental health challenge and the systematic collection of relevant data is likely to prove valuable in developing a full understanding of cause and effect and relevant mediators and moderators of symptoms, resilience, and response to interventions. In this initial outing, a sample of convenience was used and only a single time point assessed, so the results might have limited generalizability, but the now proven methods of optimizing the role and value of the internet as a tool for serious research is likely to inform mental health research even into the post-pandemic era. Results of these initial intramural research studies are undergoing peer review, so should be published in the near future. Next slide, please. Until the ongoing distribution of effective vaccines beginning earlier this year, ameliorating the mental health consequences of the COVID pandemic in the general population and specifically among healthcare workers was especially difficult in the face of the ongoing pervasive stresses associated with the risk of infection and the resulting social isolation and, for many, economic dislocation. A common theme among frontline clinicians I've spoken with, and as Dr. Lesh pointed out, is that in many cases, the pandemic has magnified challenges in healthcare that were already present before COVID. For example, a Medscape article covering a 2017 professional society meeting was headlined, quote, "Standing room only at American Psychiatric Association Town Hall on physician burnout," unquote. A national survey in the Veterans Affairs healthcare system completed prior to the pandemic documented in mental health providers a high level of burnout. Again, as Dr. Lesh described, this can be defined as increased emotional exhaustion and depersonalization and decreased sense of personal accomplishment at work. And this in mental health providers was second only to that seen in primary care physicians. Efforts being made to deal with these issues can be roughly divided between those at a system level and those on an individual level. As the largest healthcare system in the country, the VA's plan to study mental health provider burnout nationwide within its hospitals and clinics is likely to be of high interest and high impact. The conceptual model for this survey is based on the premise that workplace characteristics such as staffing and organizational climate leads to provider reactions ranging from satisfaction to burnout, which in turn results in patient outcomes and satisfaction. Or, as Dr. Lesh put it earlier, healthy workplaces improve patient care. While it remains to be seen if this ambitious study can meet its overall goal of identifying workplace characteristic and practices of facilities with low levels of mental health provider burnout that can be translated for potential implementation at facilities with high levels of burnout, remains to be seen. Institutional-based interventions to be developed and tested by the VA based on data from the survey, ideally complementary to individual-focused treatment, should prove helpful and informative as the nation emerges from the COVID years. Next slide, please. Employee assistance programs, or EAPs, provided by the employers of many healthcare workers are often regarded as poor relations when it comes to mental health treatment. Most often, these lightly staffed clinics do little more than offer screening, minimal crisis intervention, and referral to providers in the community for any significant mental health needs. In the context of COVID, though, many are seeing EAPs as the proverbial bird in hand with an already established physical and organizational infrastructure. Recognizing its inherent limitations, pilot projects are underway to upgrade their functioning. For example, EAP therapists in Michigan and elsewhere are being trained in the assessment of PTSD and the administration of a time-limited behavioral intervention, prolonged exposure for primary care, that was developed for use in the military. Next slide, please. While typical prolonged exposure therapy as a first-line treatment for PTSD requires 12 weekly sessions, by condensing the intervention to only 4 to 6 sessions, PEPC holds promise as a scalable and cost-effective intervention that can be conveniently administered in the context of an upgraded employee assistance program. A 2017 controlled trial in active duty military service members demonstrated a significant reduction in PTSD symptoms following treatment with PEPC. Post-treatment, 22% of the PEPC treated cohort no longer met diagnostic criteria for PTSD versus only 3% of a minimal contact control group. Concerns with stigma and confidentiality have historically discouraged many healthcare workers from reaching out to their EAPs for mental health issues. The development of new and effective interventions that can be delivered on site could prove helpful in overcoming resistance to accessing available care. Next slide, please. In much the same way that video conferencing had reached a high level of development so as to be readily available to be called into play during the pandemic, so too has web and app-based remote treatment development. From humble beginnings as a delivery system for static questionnaires and rating scales, the internet now powers an increasingly personalized and interactive assessment and treatment experience. When used appropriately with informed consent, what are often felt to be privacy risks can be adapted to be therapeutic. For example, the multiple sensors on the increasingly ubiquitous smartphone can track how active we are and the associated heart rates, where we go, when and how much we sleep and talk to others, and our spending, reading, and listening habits. When followed over time, changes in some of these measures can indicate, and in some cases even predict, an incipient worsening of a mental health disorder, permitting early or preventive intervention. Treatment delivery can be predicated on findings during assessment. The example shown here, called Cobalt, web-based and accessible by any mobile device or desktop, is already in use in the large PenMed healthcare system, covering over 40,000 healthcare workers in the greater Philadelphia area. In confidence, healthcare workers can obtain individual support or treatment by completing self-rating scales, for example, covering symptoms of depression, anxiety, and PTSD, to be used by the program to determine a tailored level of support. Using a stepped care model as a first line of intervention, Cobalt can link the user to asynchronous online sources of support, including curated articles and videos. Where personalized intervention is indicated, Cobalt serves as a conduit list of some 200 recommended therapists from which the healthcare worker can choose and schedule a virtual or, in the near future, in-person appointment. If a Cobalt user indicates an urgent mental health need, such as thoughts of self-harm, a clinician reaches out to the worker directly and completes a safety assessment and plan within 24 hours. Possible future refinements of Cobalt under discussion include tightening of the referral process to ensure follow-through on recommended therapist connections and appointments, with particular attention to often marginalized subgroups, including women and people of color, the latter known to have increased risk of COVID and to date a lower rate of vaccination. Next slide, please. I want to wrap up by illustrating how complementary lines of research can intersect and result in promising treatment development programs for addressing anxiety and depressive symptoms associated with fear of COVID. For several years, a number of investigators have been studying the transdiagnostic concept of anxiety sensitivity, in which an exaggerated response to minimal feelings of stress or anxiety in some people can quickly escalate to a distressing level. With the development of a standardized rating scale, anxiety sensitivity was seen to play a role in some people's COVID-specific fear, anxiety, and depression. Next slide, please. Enter an NIH funding announcement supported by a number of institutes calling for studies of, quote, digital healthcare interventions to address the secondary health effects related to social, behavioral, and economic impact of COVID-19, unquote, with a specific focus on vulnerable populations who experience health disparities, and voila, a grant is born. Next slide, please. Collaborating investigators at the universities of Houston and Oklahoma will randomly assign 800 individuals from 4 different ethnic groups, not yet limited to healthcare workers, who report anxiety and depressive symptoms related to concerns about COVID, to a 3-month trial and 6-month follow-up using a smartphone app called EASE, or Easing Anxiety Sensitivity for Everyone, that combines standard cognitive behavioral therapy with a transdiagnostic treatment for anxiety sensitivity reduction, or they might be randomized to a control condition. A particular feature of note is the use of twice-daily ecological momentary assessments, which are check-in messages from the app to ask how the participant is feeling and what they're doing. The program can then respond accordingly. For example, a subject reporting feeling anxious can be sent a video demonstrating relaxation training or encouraged to go for a walk. in what the investigators describe as a just-in-time approach to immediate personalized behavioral health care. Next slide, please. In conclusion, we've seen that while healthcare workers have faced a heavy mental health burden during a year of day in, day out stress during the COVID pandemic, obtaining help for the widespread symptoms of anxiety, depression, and PTSD has been difficult. Long-standing concerns with stigma and confidentiality over seeking mental health services were aggravated by the limited time and energy remaining in the face of increased workloads and double shifts. Promising developments include the successful testing of user-friendly interventions, ranging from a condensed form of prolonged exposure for PTSD, adapted in some places for delivery in upgraded employee assistance programs, to mobile programs accessible from anywhere, which can offer personalized remote interventions and, where indicated, arrange referrals to appropriate mental health professionals. Ongoing research that is expected to help personalize mental health treatment for the individual healthcare worker should continue to be a valuable part of the clinical armamentarium, even in the post-pandemic era. Final slide, please. And I thank you for your attention. And I believe we can now go to the Q&A session with Dr. Lesh and Deanna joining us. Thank you.
Wow. Thank you, doctors. That was amazing. And I have to say, I'm really glad that I did not pass to you all of my tongue-tiedness that I started our show with. I think from our beginning, before we got on with everybody else, it might have been the breakfast that I had this morning that you both told me that I was going to get talked to about. So for all of you, we were sharing our breakfast this morning, and my breakfast was Diet Coke. So, but anyhow, they were both amazing presentations. Thank you so much. I do want to apologize for my pronunciation of your name. I butchered that. I'm not sure how, because Dr. Lesh and I actually said of all names that I could not make a mess up was yours. And that would be the one that I did as we went through. So I do want to send my deepest apologies for that. Is one of the things I really work hard on not doing. I have a name that's not the easiest, Ziemba. So again, I apologize for that and apologize for being a little tongue-tied earlier. But both amazing presentations, so informative, so amazing on, coming through obviously a very, very challenging year and a half, and great things to share with all of us at healthcare organizations. I hope all of our attendees had the opportunity to really take some notes, get some questions together, and enjoy those presentations. So now we'd really like to open it up and welcome all of our attendees to join me in asking our physicians any questions that you may have. And I will look right here, and we do have our first question, and this is for both of you. Are you seeing improvements in your organizations amongst healthcare professionals as we come out of the pandemic?
Should I go first, Matt?
Please.
We are just beginning to come out in Ontario. Ontario, Canada, was hit with a very hard third wave. The reason my hair is so kind of out of control is because I haven't been able to get a haircut for the last 6 months because we have been still in a lockdown. That's just opened up in the last week or so. And I would say that our hospitals are just recovering now in the last couple of weeks. Our intensive care units across the country were operating at 175% of capacity. So it was just a kind of a dramatic impact on healthcare. Are things improving now? I would say very slowly, but I think that there is still, there's going to be a long tail to the mental health impacts on our healthcare providers, because we know that when anxiety is involved, it tends to generalize and it tends to propagate. So there's still a lot of work ahead in terms of helping healthcare providers feel comfortable and safe in their work environment. But I do know that organizations that have taken on the challenge of trying to be responsive are stronger and will be stronger afterwards. And organizations that have not met the challenge, I think, are going to continue to suffer from issues around morale and attrition.
I would add that one aspect of the COVID pandemic that it has been so unique and so challenging is the idea of the ongoing stresses day in and day out. The field, to a certain extent, has come a long way in terms of what's sometimes called disaster psychiatry, responding to traumatic events in the community. What's often overlooked is that, as a rule, those tragedies, whether a plane crash or a mass shooting, tend to involve an acute traumatic event followed by some variable period of recovery, but not this same kind of ongoing day after day continued stress on the system and on individuals. And so to a certain extent, the healthcare system has had to really adapt on the go, learn as we go along. I mean, sometimes the kind of joke would be, well, what did we do in 1918, which was really the last good analogous period. In looking over the literature on trauma, I was reminded of one of the classic studies that we all learned about in our training, the Coconut Grove nightclub fire of 1942, which led to the first systematic study of grief. But what's interesting and tragic is that it took only 15 minutes for that fire to claim almost 500 lives. Now, so my point is that by the time even some first responders showed up, let alone investigators, the acute trauma had ended and we were moving into another phase. It was not like there was a fire every day for a year and a half. But to end on a more positive note, whenever you go into a revolving door into a building or a hotel, look to your left and look to your right, and you will see a hinged door that opens to the outside. That is now mandated by law because that was what was missing at the Coconut Grove nightclub in Boston, and that will never happen again. In other words, we can learn from experience, and I think that's what's happening now.
Thank you both so much. We have another question here. Long term, do you think this will help eliminate the stigma for those seeking help with mental health? So this is a great question for both of you as well. Not sure who would like to.
Mullen?
All right. I sure hope so. And my answer at this moment in time would be yes. I think that we have already begun to destigmatize issues around vulnerability and redefine professionalism. So that it used to be a professional was somebody who could work 24/7, didn't have to go to the washroom, didn't need nutrition, could just carry a load without complaining. I think we're more attuned now to people's vulnerability. And by making that a kind of real concern that belongs to everyone in healthcare, it becomes possible now to provide more access to care. I think it starts at the top, as I said earlier. Leadership has to be transparent. In the leading groups that I've done for the Faculty of Medicine, for senior leaders at the University of Toronto, I keep hearing reports from people saying that the more transparent they are about their concerns, the better engagement they have with their colleagues, their residents, and people who work with them. So I would say we have this is part of what I hope becomes the opportunity that we harvest from this terrible calamity. That we are more respectful of one another. We improve issues around social justice and healthcare, and that we improve access to mental health care. And I'm optimistic about that. And although we've talked about continued vulnerability, I think we also need to talk about resilience. That there's enormous amount of resilience and grit in the vast majority of healthcare workers. We have to kind of remove obstacles to them implementing and engaging that.
Thank you so much.
I would add that I think that the rise of mobile app-based interventions might be helpful here in terms of normalizing the concept of seeking help. You know, to be able to access the kind of program I was talking about, like Cobalt, on your smartphone in confidence, lowers the bar for people who might not rush out to make an appointment with an actual mental health professional, and it offers this kind of step care approach where if people do need more intensive intervention, they can work their way up to that and ultimately get a referral. But the thing is, if you've got 40,000 people in a healthcare system with this on their smartphone, and it's not seen as a big deal, so, you know, okay, I was feeling kind of anxious the other day, and Cobalt sent me a nice yoga video that I played after work. No, it really can help with destigmatizing. And certainly, again, I think that's the hope with the limited research that's starting in the employee assistance programs, where people have been reluctant often, you know, to set their foot in the door for fearing that's going to show up in their employee records, or that's going to get them into trouble. And I think that certainly healthcare systems are now recognizing it's important to ensure confidentiality, that health records are separate from personnel records. And I think that that too will be helpful in terms of the destigmatization.
Wonderful. Thank you so much. There was a second part to that question that said that indicates or asked, do you see long-term help at your organization? So kind of in addition to eliminating that stigma, do you see that there's an opportunity to see long-term help from your organizations?
I would say that the organizations that I think do the best in the face of these kinds of challenges are ones in which mental health resources are embedded in every part of healthcare. That we don't have a kind of silo of mental health over here, medical health over here, but that we work in a collaborative fashion, and that we elevate the importance of mental health equivalent to the importance of medical care. So embeddedness, kind of being part of the team, collaboration. People are less likely to turn to mental health support if they don't have a prior connection, experience, exposure, relationship. So build now. Now is the time to invest in the human capital of your organizations. Now is the time to teach and train about trauma, stress reduction, implementation of ways in which people can manage the professional demands, so that they have that to come back to when the rubber hits the road.
Wonderful. I really appreciate that response.
Yeah, so I would only add that in a funny way, the COVID pandemic has enabled or forced people in general to recognize how physical health and mental health go together, because it's clear that quite beyond people who actually have been infected by the virus, so much of the population has been impacted by the secondary effects of the lockdown and quarantine and social isolation of much of the past year. And so the concept of mental health being an integral part of the overall challenge of COVID, I think, has permeated people's consciousness in a way that we really haven't seen before. And even with a lot of the media coverage, that's been pretty clear. And every time I've been on the Zoom call where somebody apologizes because their child is using some of their bandwidth to do their online homework, is a kind of reminder that people's lives have just not been the same for some time, and that's had a real mental health impact on many.
Thank you so much. I'd like to take a moment to thank both of you again for your amazing presentations. We are coming to the end of our time today. Very informative, very helpful, great, thoughtful information and ideas for all of us. So again, thank you both for your time, for your efforts, for your presentations today.
Pleasure. Thank you
Thank
for the
you.
opportunity.
Thank you for joining us today for our second session of the Sara and Samuel J. Lessans Symposium. Our third and last session will be held on June 24th. We will focus on a journey through the pandemic. We've got some great presenters that are lined up for that presentation. You do not want to miss that. We have our own Dr. Gil Perez, Senior Vice President, Medical Affairs, Chief Medical Officer, Medical Director here at Charles E. Smith Life Communities. We also have, Dr. Sonia Kasbah from Suburban Hospital joining us. And we also have Dr. Isha Misra from Johns Hopkins Community Physicians at Suburban Hospital joining us as well for that presentation. For additional details and registration, please visit us on our website at smithlifecommunities.org. As a reminder, please look for the survey in your email, and we look forward to seeing you next week. Thank you so much.